So, dear colleagues, it's 6:30 p.m. in Europe. My name is Morgan Roupré. I'm a professor of urology in Paris, France. I'm pleased to be surrounded by talented faculty tonight. I have Professor Laura Mertens from Amsterdam. Thank you, Laura, for being there. And I have Professor Paolo Gontero from Torino, Italy, and chair of the NMIBC guidelines. The topic we'll address tonight, obviously, is going to be urothelial carcinoma of the bladder. And we'll talk about hot topics in the field of bladder cancer, especially bladder preservation, because outside the drugs that are in the pipeline, the surgery has changed, the landscape is evolving. So we will try to address all the issues. And of course, as a guest and an attendee to this webinar, you can raise questions through the Q&A of the Zoom link where you are connected. So do not hesitate to interact with us. We'll try to address all your questions as much as possible. We'll start immediately with Professor Mertens about personalized medicine in bladder cancer. Where are we now? Vast, broad question, Laura. So please try to answer it, and we'll discuss with you and Paolo at the end of your talk. Thank you so much for being there tonight.
Good. Thanks a lot for the kind introduction. Ladies and gentlemen, indeed, broad topic, personalized medicine in bladder cancer. Actually, we are recognizing that bladder cancer is just not one disease. That's very important. And I think in daily practice, we all recognize this heterogeneity. I mean, one patient responds well to BCG, another might have been better off with an early radical cystectomy. Same question for muscle-invasive bladder cancer. Why does one patient respond perfectly to neoadjuvant therapy? Which patient can undergo bladder-sparing treatment? And identifying these factors, that is personalized medicine. And with the growing interest in bladder preservation, this has become increasingly important. And actually, personalized medicine here means going beyond stage and grade and towards integration of tumor biology, but also patient-related factors and treatment response, with the goal of selecting the right treatment for the right patient at the right moment. And in the context of today's webinar, this integration is particularly relevant when we consider bladder preserving strategies. That said, I would like to remain realistic because outside of research settings, we currently actually do not really have a lot of tools that can be applied in clinical practice. So I don't have a golden solution for you today, but what I do hope to provide is a snapshot of where we stand now and a glimpse of where we may be going in the future, in the near future. So let's start with non-muscle invasive bladder cancer. One of the biggest issues here is distinguishing patients who require radical cystectomy from those who benefit from additional lines of bladder-sparing treatment. 4 personalized solutions. First of all, tissue. We can have a look at the tumor tissue, and we know there's a lot of variation in terms of molecular and genetic backgrounds of different non-muscle invasive bladder cancer. And people have used sequencing to determine or to predict BCG response. But although theoretically very interesting, translating these strategies into clinical practice has proven extremely challenging and is therefore not ready for prime time yet. A second solution is ctDNA. We know ctDNA is a great prognostic factor in muscle-invasive bladder cancer, but also in NMIBC, ctDNA has been evaluated, although on a much smaller scale. Very interesting, very recent data here. What was found is that approximately a quarter of patients with BCG unresponsive NMIBC become ctDNA positive, and that ctDNA positivity is associated with unfavorable prognosis. So this could become useful in the non-muscle invasive space in order to select patients who should not attempt any further lines of intravesical treatment. But of course, this needs to be validated in larger series first. A third option is urinary tumor DNA, a very logical marker, I think, to guide personalized medicine in non-muscle invasive bladder cancer. This was investigated, for example, in this trial among BCG unresponsive patients receiving systemic IO. Patients with positive urine tumor DNA were less likely to respond to treatment and had a higher chance of cancer recurrence. So, a marker for worse outcomes after therapy, and the test could potentially help to make better decisions regarding possibilities for bladder preservation, but again needs to be validated first. And then finally, for NMIBC, I would like to discuss AI-based risk stratification. This, in my opinion, could be the ultimate form of personalized medicine, as it looks beyond traditional grade and stage, but includes multiple factors that are not included in traditional risk models. An example here is the program VCA, unpronounceable, but it's a recently developed risk model designed to improve progression risk assessments using AI approaches. And this model has shown to outperform the 2021 EAU risk model in predicting progression. At first glance, these AI solutions may sound like a rather abstract or distant development. However, this type of AI-based stratification is already finding its way into clinical guidance and will be reflected in the updated guidelines. So it is a rapidly evolving field. And then we move to muscle-invasive bladder cancer, because here, in fact, it's all about response to neoadjuvant systemic therapy. First, standard cisplatin-based chemotherapy. Then, over the past years, a growing body of evidence has emerged for neoadjuvant immunotherapy, monotherapy, combination regimens, often showing high response rates. Then the combination EV-pembro, high response rates in the cisplatin ineligible setting, and what will be presented at ASCO GU this year is data of EV-pembro in the cisplatin fit setting. And this probably is going to be a game changer. And with response rates at this level, an important question is, can we safely move towards a more bladder-preserving, response-adapted approach? And a good example of such a personalized approach of dynamic selection is provided by trials led by Matt Galsky, but also, for example, by the RETAIN trial. And in these studies, patients with muscle-invasive bladder cancer who achieve a complete clinical response after neoadjuvant therapy are offered active surveillance rather than immediate cystectomy or radiotherapy. And while not all endpoints were met, a meaningful proportion of patients avoided cystectomy without developing metastatic disease. And these studies at least illustrate the potential of dynamic selection, and are now being further tested with other more powerful neoadjuvant agents. But I think these studies also demonstrate that we actually really need accurate, non-invasive imaging biomarkers for treatment response prediction. And that, in my opinion, will be key. But the question is, how do we get there? One solution might be imaging, MRI, and especially MRI-based tools that allow us to move beyond straight response categories. And I would like to show you this case of a patient with a CT4A urothelial carcinoma of the bladder. You can see this here on the MRI. The patient was treated with neoadjuvant immunotherapy, and then an MRI after neoadjuvant therapy was made, where you can still see tumor into the perivesical fat. So from virus 5 to neck virus 4, and then ultimately pathology indeed confirmed a YPT3 disease, but, and I think this is an important nuance, the specimen shows predominantly necrosis with only minimal viable tumor. So despite presence of tumor in the perivesical fat, this does represent an almost complete pathological response. And this level of detail is easily lost when we solely rely on traditional categorical response classifications. And this is work of our PhD fellow who tested the hypothesis that it might be better to not only rely on these categorical variables, but to make response assessment more personalized. So she analyzed the data of patients treated in neoadjuvant immunotherapy trials, first using categorical criteria, but also continuous measures, such as tumor diameter and volume. And what we found is that these continuous parameters allow more accurate prediction of response. And importantly, they also improve reproducibility between the readers. And at this moment, the approach was limited to size and volume, but I think it's easy to envision how additional variables could be incorporated. And this could open the door to more refined response criteria, potentially including radiomics. But of course, there's more than imaging. However, unfortunately, so far, there's insufficient evidence to use any of these markers in clinical practice, and this will remain unchanged in the 2026 guidelines. I would like to discuss ctDNA here with you again. As I said earlier, most robust validation data comes from the adjuvant setting, but there's growing evidence that ctDNA may play an important role in the neoadjuvant setting as well. Absence of ctDNA or clearance of ctDNA has been associated with pathological complete response in smaller neoadjuvant immunotherapy trials. And this concept was reinforced by the Niagara trial. Here, ctDNA was not completely predictive of a complete response, but almost all patients who were ctDNA positive before cystectomy failed to achieve a pathological complete response. And in this light, I think that the results of the INDIBLADE trial will be particularly interesting. These data will be presented at the ASCO GU as well, and they explore neoadjuvant immunotherapy followed by trimodal therapy, and specifically whether absence of ctDNA after systemic therapy is associated with bladder intact event-free survival. So I think that's a second must-watch. Another must-watch is the urinary tumor DNA data of the Niagara trial, which will also be presented at ASCO GU. Again, we know from smaller studies that absence of urinary tumor DNA may be associated with local complete response. This also sounds logical, but again, this needs to be tested in larger settings. So together, these developments suggest that molecular response assessment may become a key component of personalized bladder preserving strategies. And finally, I think this is an often underestimated component of personalized medicine, and that is the patient perspective. As tumors, also patients are heterogeneous. It's comorbidities, functional status, but also personal priorities that can be completely different between patients. I mean, some are willing to accept intensive surveillance and a degree of uncertainty in exchange for bladder preservations. But also, as shown in the sister trial, definitely not all patients prefer bladder preservation. So true personalized medicine requires shared decision-making where also patient values are explicitly discussed and aligned. So in conclusion, in my opinion, the future for personalized medicine in bladder cancer is bright, but it will not be defined by a single biomarker or technology, but most likely by our ability to integrate different sources of information to safely enable bladder preservation. Thank you.
Thank you, Laura. Obviously, there is a lot to come. And as you mentioned, that the pipeline is extremely active, and especially for the ASCO GU coming in 3 weeks from now. You told us that there were some data that are going to be released. Do you see a revolution or an evolution in the way we treat also bladder cancer according to systemic treatment? Because we see a lot coming from the metastatic field. And we were at ESMO before going to ASMO, and We had all the data which were released for the unfit patient, for cisplatin and so on. Do you believe that we are in an era, or logically, all the drugs that are in the metastatic fields are going to be used in a curative intent to try as much as possible to cure the patient and ultimately to spare the bladder?
Yeah, I think with all those new very active neoadjuvant agents, I mean, what do you expect from EV Pembro in the cisplatin fit group? I think we are moving more and more towards bladder preservation. In fact, but you're probably going to discuss that as well. You don't need to have a complete response before you go to trimodal therapy. So that might not even be the way to go. I think the ultimate way to go is with response rates, complete response rates up to 60%. The target should be to accurately identify those patients. And then maybe they don't even need to go for trimodal therapy anymore, but they can just go for a wait and see approach. So I think that, in my opinion, will become a revolution. Curious to hear your thoughts, by the way.
I'm perfectly in line with you because I think we take out more bladder than ever, and I think that it is going to decrease. And so the way it is proposed by certain radiation oncologists is not, I believe, the way to go, because some of them want to skip TURBT and use the MRI and so on and so on. I believe there is still room for endoscopic surgery, but we will definitely take out less bladder. The question is how to select the patient. And we are in an era where endoscopic T0 was before impossible to consider for the preservation. And now there is this possibility with the molecular imaging and so on to look at the micrometastatic phenomenon. Of course, we are looking for more markers, very accurate markers and so on. But I believe that we can track on the micrometastatic disease in a way which has never been so accurate. So it's not ready for prime time, but I think it will evolve quickly. And I would like to open the discussion with Paolo also on this point.
If I may ask a question, Laura, you were mentioning the wait and see, and this concept it was really considered impossible by the guidelines, the muscle-invasive bladder cancer metastatic guidelines. And the question is, how do you see this recommendation evolve in the near future?
Yeah, I believe that at this moment, such a strategy is not ready for routine clinical practice. It still needs to be validated in larger randomized trials. So at this moment, it's not ready for the guidelines, but I do expect this to evolve. There are more and more trials opening, for example, also on EV Pembro, followed by a risk-adapted approach. And I do think this will be the way to go. It doesn't mean that as a patient, you have to opt for surveillance, for example. I mean, there's many reasons why a patient would want to go cystectomy or trimodal therapy. But I do believe that if we are able to accurately predict response, wait and see might become a more accepted option in the future.
Thank you.
Okay, no question in the chat at the moment, but if there is any, do not hesitate. We will try to summarize the questions you want to address at the end of the lecture. So I will immediately jump into the three modality treatment. As a urologist, I've been asked to defend the radiation oncologist, and I'm super happy to do that, especially after the debate I had on Twitter very recently. Partager, yes, I share my screen. And I put that, okay. So to be very honest, it is true that for many, many years we have been doing a lot of cystectomies in advanced bladder cancer, locally advanced. And it was unclear whether or not trimodality treatment was equivalent to cystectomy. It is now a reality in the guidelines, very solid, robust, and not only the radiation oncologists are pushing for trimodality, also the patients, they are more involved in more and more involved in the guidelines dissemination as a lobby and so on. And it is true that there are many cases where the patient could see or enforce the possibility to preserve their bladder. The question is not only to preserve the bladder, we do not want to compromise the oncological outcome. And on top of that, if this is the case, what we do like to preserve is a bladder which is functional. And you will see that in terms of bladder intact index, it is interesting that the lack of evaluation that we have at the functional level in terms of urodynamics is a bit sometimes complicated because most of the studies are dedicated to oncological endpoints. These are my conflict of interest. So I work in Paris, France. I locate it on the map because sometimes people are disoriented. And this was I stay very humble because this was the promotion which was made of this webinar. So I thought, as a urologist, I was known in France, and this is the picture which was sent. So probably the participant or somebody who is going to replace me very soon. So look at this guy. He will become probably very important. Obviously, he has been chosen by the EIU to replace me. So what is the rationale behind the rationale behind the trimodality or the bladder preserving strategy is that in many areas of oncology, ENT, colorectal cancer, breast carcinoma, esophageal carcinoma, lymphsarcoma, you try as much as possible to preserve and to destroy the tumor on site. One of the quotes which has been becoming famous was coming from Anthony Zittman, saying that the best bladder you will ever have is the one you are born with, even if it has had an aggressive TURBT and some radiation. And what is between brackets needs to be discussed according to me. But anyhow, it's a good starting point. So GU cancers management is multimodal, and I think if we are here tonight is to let you know that there is no way you can treat advanced bladder cancer without discussing with medical oncologist or radiation oncologist. So one of the key points and that we need to bear in mind, either as the stage of non-muscle invasive bladder cancer or locally advanced, it has to be underlined that the TURBT has to be exhaustive, complete, and very accurate. Otherwise, the treatment will not be as efficient as expected. And then you can encompass the possibility to have a full dose of radiation and of chemotherapy. But if there is residual tumor after a second look evaluation after the treatment, then a radical cystectomy can be considered, and there is room for salvage radical cystectomy, which can be a little bit more difficult, and you can increase the morbidity. In 10 up to 20% of cases, you can face this situation. So if there is just one slide to bear in mind, is probably this one, how to see who is the good candidate for TMT, three-modality treatment, is the patient selection for bladder preservation. And to be very honest, the patient with the good candidate for bladder preservation is also the patient with the good candidate for radical surgery. And in fact, surgeons who are, I would say, reluctant to do radiation therapy are going to refer the patient when they are facing a T3B or T4B situation, say, look, you should do a chemotherapy plus radiation therapy. This patient is very difficult and not suitable for surgery. But the reality, if it's difficult for surgery, it's also difficult for the radiation oncologist. So the bad candidate for TMT is not a good candidate for surgery and vice versa. So it's very important to bear this in mind. The other point is whether or not hydronephrosis or existence of CIS could be some criteria to select the patient or to avoid the TMT and the bladder preservation. So complete response is the key objective. And you see that the complete response rate according to the invasiveness of the tumor is a bit different. You have some survival curves, very interesting from this article from the GCO. And for you, we need to agree on the definition we give, because the definition is based on the cytology or no ability to depict any tumor at the time of cystoscopy or the TURBT. Of course, the evaluation is going to be endoscopic, and all those trials that are been published a long time ago, you can guarantee that the accuracy of the imaging was not as good as it is today. So it is important to understand that all along the way, the quality of the endoscopic surgery, the quality of the radiation oncology, and the quality of the evaluation has changed. But one of the key issues in three modality and bladder preserving strategy, the way we see it and the way it's depicted in the guidelines, it's three modality. And one of the modalities is endoscopic surgery, and it's not a biopsy, it's a TURBT, transurethral resection of the bladder, of quality related to complete response. And it is absolutely depicted everywhere in the literature. And if there is no complete TURBT, you can see the difference in terms of statistics and complete response rate. It's absolutely demonstrative from all the paper we have, the older paper and the more recent paper. So far, hydronephrosis is not a contraindication for TMT. It is true that the complete response rate is impacted by the existence of hydronephrosis, but it is not a formal contraindication. It can be done from time to time. It's exactly the ability that we have within a tumor board discussion to read between the lines of the guidelines and to say this patient is in particular situation, he has several comorbidities, the anesthesiologist would be reluctant, and so there is no reason why the patient should not be selected, but it is true also that when you display hydronephrosis at the start of the treatment, then the complete response is less important. Another point is to see whether the hydronephrosis is bilateral or unilateral, because you can see that according to this criteria of stratification, the survival curve is a bit different when there is unique or bilateral hydronephrosis and according to the invasiveness of the tumor in the bladder wall, or the T2, the T3 with no hydronephrosis. And on top of that, there are differences, discrepancies among the literature between registry, real world evidence, and the reality. And so the OS with preserved bladder cancer, you can see that at 60 months is not that bad. And you can see that in the lower plot, salvage cystectomy was taken as an additional event. So it's not a new concept. It is something which has been designed a long time ago. It took time to be incorporated into the urological guidelines. But the reality is that in the patients that are fit and with the criteria that are displayed in the first slide, you can see that localized disease, unique tumor, T2 and so on, you can expect to have a good oncological outcomes, good complete response, and a very acceptable 5-year survival rate, according to what we know from the literature. There was this paper, and you can see that according to the lecture that I'm presenting to you tonight, that the quality of the paper is increasing along the time. There was this Razor trial about robo-assisted radical cystectomy versus open radical cystectomy. This is a comparison between two surgical approaches. But after there was the paper about the tolerance following TMT, which is excellent because we need to talk about the quality of life. And it's not easy to evaluate in terms of bladder cancer. As I told you, there are certain survey or scale of quality of life that you applied in oncology that you could not apply in the field of urology, because there is, of course, the toxicity of the treatment itself. But as I mentioned initially, There are some patients that are cured from cancer, but they are still complaining about the quality of life and the impairment in the mixtion and the pain, which was triggered and generated by the treatment itself. And late toxicity can happen. Immediate toxicity is not around the treatment itself. So the quality of life following TMT is good, but we have to see on the long run. If we took it at large, if we want to have a broad vision, and when you question the patient about whether or not they would be happy with their urinary condition in the way it is now, you can see that 18% of them are delighted, 50% of them are pleased, and mostly satisfied, 17%. So you can still have local relapses. You know, you don't have the 100% of control. They are manageable when it's detected. So it means that you need to have a collaboration between the urologist, the radiation oncologist, and the pathologist. There is local relapse in up to 40% of cases, and locally infiltrant relapse nearly 20%. This is where you need to consider early salvage cystectomy. Some patients are not eligible for surgery. Some patients are eligible, but 20% of them are going to refuse or they don't want to hear about surgery. So what is important is to see what is the complete response. What we have the T0 after dose back or gemcitabine cisplatin. And remember that if you undergo surgery, in the vast majority of the cases, the systemic chemotherapy will be discussed as well. So it's a long journey, either to go into neoadjuvant chemotherapy plus cystectomy, or to go into the three modality. And ultimately, some of the patients which went into the preservative strategy will end up with a salvage cystectomy. It has to be stated from the beginning, but not the majority of them. It's difficult to compare the two treatments because there were some trial, and notably one which was released in the BGUI with the population which was randomized between group 1 and group 2 for selective bladder preservation. But you can see that in the conclusion, they are saying that a randomized phase 3 trial comparing selective bladder preservation and radical cystectomy after neoadjuvant chemotherapy was not feasible. So the flow chart is misleading the potential readership, and it's very difficult to assess this kind of comparison, to be very honest. There is the paper from Zlota, which has been released at the ASCO GU 2-3 years ago, if I remember correctly, about the comparison with the radical cystectomy and three modality. But the reality is that it was done in very expert center, selected population. It's complicated when you look at the stage of the patient, the existence of hydronephrosis, so the population was not really the same, and I'm not so sure that the comparison was really fair. But ultimately, it is saying that as a takeaway, that the three-modality therapy is a very solid option in selected patients, and I told you how to select that. So what we have learned from Alexandre Zlota is probably that radical cystectomy remains the gold standard, but honestly, you see the rate of salvage cystectomy is only 13% in the very recent population. The number of recurrences was 20%, and the low recurrence rate was 8%. So salvage cystectomy is feasible. More and more publications, more and more teams are dealing with this option. And it is true also, and we have to be honest, that the morbidity of salvage radical cystectomy after TMT is more complicated and more difficult, and probably has to be done in centers that are experienced with this kind of surgery. So when you look at the guidelines, when you look at the EAU, there is a consensus statement. You can see that from the EAU ESMO consensus statement that any candidate for curative treatment such as cystectomy should be clinically assessed by at least an oncologist, a urologist, and a radiation oncologist. So we need to be open-minded. Of course, if the medical oncologists and the radiation oncologists are mentioning in their guidelines, we have some retrospective data from the SEER database at the large level in the United States showing the differences according to the age and the fact that in elderly patients, probably cystectomy is not always the best option. So these are the EAU guidelines, and you can see that remodality therapy is equal, is not is a solid arrow. It's not dot points. It's a reality. It's mentioned in the pocket guidelines as well. Long-term survival rates of TMT bladder preserving treatment are comparable to those of early cystectomy. And as a takeaway, I would like to say that the current standard of care of NMIBC is morbid, and by that I will reach the presentation from Professor Mertens. Each modality is associated with significant long-term toxicity. We need to de-intensify and probably to select the patient and to determine how we can assess complete response, probably with cytology, CT chest, cysto-TURBT, and now UTDNA, MRI, or ctDNA. And there will be more in the basket, and we will have more in the armamentarium, but we need to understand that these tools, these biological tools, let us enter in the field of personalized medicine where the strategy, the bladder preserving strategy is going to be challenged. And also, as we are challenging radical cystectomy, the way we do the TMT today is going to be revisited, and because it's a little bit outdated, and we need to consider a bladder preservation strategy, which is going to be different from what we have been doing so far. So at the moment, TMT, I would say, is the best surgical treatment because we have endoscopic surgery. It's a multimodality. It is true that it is a robust option, defended in the guidelines, but also TMT is going to be challenged in the way it is delivered today, and there is no doubt that the new drugs coming in the market are going to re-challenge the way we perform the TMT today. So thank you, and if there is any question, I'm happy to answer. Otherwise, we jump to Professor Gontero.
Thank you very much, Morgan. If I may just ask you a quick question. You actually pointed out very clearly that the crucial role of a complete TURBT as a tool to achieve the best results of trimodal therapy. Now the question is, how do you position these new ideas to actually avoid at all TURBT by combining an MRI and a bladder biopsy in order just to jump straight away to a trimodal therapy and just leave the tumor in, claiming that this could achieve good results?
Yeah, I don't believe in this concept. I discussed a lot with Nick James in many debates and in many congresses because he's traveling all around the world carrying this idea that we could skip that. With the biopsy, first of all, you have less information compared to the whole amount of tumor you are going to bring back to the pathologist in terms of prognostic decision, choice of systemic treatment, and so on. And on top of that, I agree that the MRI, and I know the job, the fantastic job which is done by Valeria Panabianco and all the team about the VIRADs and so on. But I think for the moment, it's just a concept. And I don't think that today there is a way we can overcome. We can certainly overcome and consider to overcome cystectomy, but there is no way we should consider to overcome TURBT. And I think it's a message I want to send tonight and make it very clear. We'll have a consensus between experts tomorrow in Vienna. And I'm sure that if we raise this kind of question, I don't believe, but maybe I'm wrong, that the majority of the people, regardless of what they practice and what they preach, they believe in the concept of Nick James.
I also have another quick question.
Please.
What do you think? I mean, usually people have a muscle-invasive bladder tumor and then decide to go for surgery or trimodal therapy, and then make the decision for neoadjuvant therapy. What do you think about the concept of starting with neoadjuvant therapy and then deciding on definitive treatment? Do you have an opinion about that?
Yeah, this was the exact last slides that I presented in my lectures. It's like the T0 endoscopic patient, the reevaluation after neoadjuvant chemotherapy. The concept is that we have a neoadjuvant treatment. So the main treatment should be cystectomy, and we deliver the chemo, and some of the patients and some of the physicians are considering that the treatment is done, and we could skip the surgery. It's difficult to answer. I would be comfortable if we had any molecular imaging that would make me comfortable saying there is no activity, no CN plus, no metastatic phenomenon. The reality at the moment, and Jean Cato tried to randomize this patient between cystectomy and so on, and he said it's impossible. The patient are refusing. So we will have no answer from evidence-based medicine. I think that the patient are going to be reluctant to enter such a trial. So we need to find a way to assess that the endoscopic evaluation is done very accurately. So this is true in my experience. I have 2, 3, 4, 5 patients maybe that have been going into this track and are still alive with their bladder and so on. But it's very, very, very tricky to select the patient properly. And I don't feel always comfortable to, when we are doing a course like this or a webinar to educate people and to try to increase the awareness around bladder cancer, I don't feel comfortable to say this is a solid option today.
Morgan, I think there is a very appropriate question that
Yeah.
came from the audience, and it's related to trimodal therapy. A patient who has indication for trimodal therapy, but not fit for chemotherapy, meaning that he has chronic renal failure. Would you prefer radical cystectomy, or you don't have to just give cisplatin for trimodal therapy? What is your comment?
But in fact, chemotherapy has nothing to do with dose dense, for instance. It's another chemotherapy, which is a lighter one. And when you discuss with medical oncologists, they can even adapt or change the regimen and so on. So they always find a way. The thing is that we used to understand that the regimen of chemotherapy, as soon as we start chemotherapy in bladder cancer, is always the same, is as difficult to go through. We have to know that in the US, for instance, they are not sticking at all with dose dense. I don't know what you do in Italy or Netherlands, but in France, we stick a lot with dose dense due to the Vesper trial. But I think ultimately that the regimen which is done in the US is going to be the lighter one, the one we will stick with. And even I believe that the chemotherapy will be eradicated with the Pembro-EV combo. So I think that for the moment, I've never seen a medical oncologist telling me that it is impossible to do the three modalities. They always find a way around using carboplatin or some other regimen. And it's not radiotherapy alone. Never. Paolo, we should go to your talk because we are running out of time and I want you to have a sufficient amount of time to present your slides. Thank you.
So the topic that I'm going to address is actually the BCG naive high-risk population. So we are not going to talk about the BCG unresponsive. These are my conflicts of interest. For high risk and very high risk non-muscle-invasive bladder cancer, the cornerstone treatment is BCG. Of course, radical cystectomy has to be discussed, and of course, has put as an alternative to the very high risk population. But first of all, if we want to go beyond BCG, we need to ask ourselves why BCG became the gold standard treatment for high-risk non-muscle-invasive bladder cancer. It was actually based on several randomized studies. Here you can see the most representative. BCG was actually superior to intravesical chemotherapy, in particular mitomycin, only for recurrence. But it was not proved firmly that BCG was superior for progression. And also, BCG was superior to chemotherapy only when it was given with maintenance. If you don't give maintenance with BCG, actually, there is no difference. So the message is that BCG is the best only when it's given with maintenance. And also, there were randomized studies showing that in the high-risk population, probably the best maintenance treatment should be given for 3 years. That was going to be the more appropriate. But when we look at the subgroup of the very high risk population, the question is, how is BCG working? Because we know that there is a strong recommendation for radical cystectomy and BCG as an alternative. You can see that we only have retrospective evidence, and you can see that these two studies actually almost say the same, that the risk of progression with BCG is decreased significantly, but still remains high, around 20%, meaning that probably BCG is not effective. And also we have a problem with recurrence with BCG in the long term. Up to 5 years, 50% of the patient will fail BCG, and the majority of these patients will be high-grade BCG recurrence, meaning that they will be called BCG unresponsive. Then we also have a problem with tolerability of BCG. If we look at the Nimbus trial, which compared two different regimens of BCG, and the aim was actually to try to demonstrate if a reduced regimen could be equally effective. You can see that one out of two patients was not able to complete the BCG regimen of the long-term treatment of 3 years. So we have the scene where we really need to move forward to BCG. In the high-risk population, there is not really an impact on progression. We have a very, very good impact on recurrence. In the very high-risk population, the risk of progression remains quite high with BCG. And also we have the patient that cannot tolerate BCG and the issue of BCG shortage. How can we move forward? First, we can improve the efficacy of BCG, or we can just replace BCG in the patients that are actually non-tolerant to BCG. And of course, you all know about this combination of BCG with immune checkpoint inhibitors. There were 3 trials, randomized trials, and you can see that except in one trial, the other 2, the Potomac and the Crest, showed a meaningful improved event-free survival, which was a meaningful endpoint in patients receiving the combination of BCG. And of course, this was certainly an interesting point, and it was corroborated by a very high evidence. Of course, combining BCG with immune checkpoint inhibitors had a rationale because PD-L1 upregulation seems to be actually a mechanism of BCG resistance. But there was also a second lesson learned by this trial, and particularly on the Potomac and the Alban trial. And the lesson was that for some groups, subgroups of very high risk non-muscle-invasive bladder cancer, this combination seemed to have a better and more favorable hazard ratio. In the Potomac, it was a higher papillary disease, and in the Crest, it was a subgroup of CIS patient and T1 patient. But there is a third lesson learned from these trials. And the third lesson is that if we look at the BCG-only arm, we can conclude that more than 70% of patients who were treated with BCG alone in the control arm, actually they were disease-free at 3 years. And this certainly is a very interesting point because the literature was totally devoid of large trials on BCG, randomized trials on BCG in a high-risk population. And also, another important point is that if you compare the combination in patients that did not receive maintenance in the combination arm, there was no difference at all, meaning that indeed the maintenance BCG is also crucial if you use the combination. There is also another possibility to combine BCG, is the combination with interleukin-15. And this has been addressed in the BCG unresponsive. It has been approved by FDA. But you can also look at this quite old study where this combination was assessed in BCG naive, and some of these patients were actually CIS patients, and you can see that it was really, really promising. So this kind of combination is probably also possible to be addressed in the BCG naive patient. But if you want to change completely, so just to find an alternative to BCG, certainly the combination of gemcitabine and docetaxel intravesically is promising, not only for the BCG unresponsive, but also for patients who are BCG naive. And you can see this is just a preliminary study, a study on high-risk patients, some of these patients with CIS, and you can see the curve. This is a relatively short follow-up, but the curve is certainly very, very interesting, and we do have actually a randomized study comparing BCG with the combination of gemcitabine and docetaxel, the Bridges trial, which will probably tell us whether this combination is actually able to replace BCG. Or, to stick to the first lecture, we can move also to a personalized approach for patients with high-risk BCG naive non-muscle-invasive bladder cancer, thinking about the fact that the mutation of FGFR receptor is more prevalent in the non-muscle-invasive bladder cancer cohort. And indeed, there is this TAR-210, which contains erdafitinib, which can be placed in the bladder for continuous delivery of erdafitinib. And you can see in this preliminary study on 21 patients, these were actually patients who were BCG exposed, but still the short-term results of this study, with 90% of patients being recurrence-free at 12 months, points out the possibility that this could really be a realistic, very good alternative to BCG. And the Sunrise 3 study that is assessing the role of TAR-200, who is an intravesical delivery system for gemcitabine, is also going to tell us whether this combination will be competitive with the BCG in the BCG naive setting. So you can see that there is a treatment armamentarium of alternatives to the current role of BCG, which probably in the future will certainly allow us to have a very, very good alternative. So in conclusions, the monolithic BCG-centered approach in high-risk non-muscle-invasive bladder cancer has limitations because we have a problem with efficacy, with 50% of the patient that will eventually fail BCG, and not all the patient will respond, of course, in the first instance. We have problem with the tolerability. And the first-line BCG combination have shown evidence of an added efficacy. Although we have to realize that we have promising, innovative alternatives to BCG, which are under evaluation, and also possibilities for targeting the FGFR mutation in a personalized approach. And finally, I think that these premises also made us to consider the possibility in the future to remodulate the definition of BCG unresponsive, because BCG will not longer be the cornerstone for primary treatment in high-risk non-muscle-invasive bladder cancer. Thank you very much for your attention.
Congrats, Paolo. Excellent presentation. Can you hear me? Yes. Okay, thank you. I think we have opened the Pandora's box about the 3 trials that were released that year. I was running one of them, which was negative, unfortunately. It was called Alban. There is Crest and Potomac. There is Fred Widges online, and he's asking you whether you value the side effect of immunotherapy, which are around 25% of grade 3 and 4, BCG naive versus the 5-8% gain in EFS, which is not overall survival. How do you see that? Knowing also that Pfizer has just removed their authorization they were requesting for the FDA approval with the sazonlimab. So knowing that they have a phase 3 positive trial and they just step out from the process of gaining the positive answer. So what do you see there? And do you believe in the concept of systemic treatment in NMIBC?
Well, I think that you are pointing out the main problem of this combination, which is of course the toxicity that we have to consider. But we also have to consider that until recently, the very high risk subgroup of patients was actually going to be canceled straight away for radical cystectomy, and I still believe that in many centers this is the case is not even offers the possibility of a bladder sparing approach. So in this scenario, I think that if we carefully select a patient who has a very, very high risk of progression, probably this could be the patients where you could consider the combination of treatment. But certainly the possibility of bladder sparing approaches in the evolving armamentario in the BCG unresponsive population, because we have to consider that BCG anyway is a highly effective treatment in high-risk non-muscle invasive bladder cancer. So I think that in this scenario, probably I mean, the combination of BCG as primary treatment has also to be weighted to the possibility to have nowadays and in the future in Europe a lot of potential alternatives in those patients who will fail BCG.
Laura, any question from your side?
Well, I think the same message that we've highlighted a couple of times before. I don't think there's one perfect treatment for everyone. And for that reason, it's quite difficult to recommend a certain combination for all patients. But it might be worthwhile to offer the combination to patients with the highest risk as soon as we will be able to identify them.
And one other question, Paolo, is about the way we deliver the instillation, because we see that today we put a bladder catheter, we put the product within the bladder, and we ask the patient to hold it as much as possible. This is the reality. And today you just mentioned that there will be the possibility maybe to disseminate the drug in another manner within the bladder. And the first step is probably to use the TAR 200, which is not perfect because so far it's called the pretzel, but the extremity of a double G stent, let's say, loaded with chemotherapy. So we have learned from the guidelines for many years that in a high-risk group of patients, when there is CIS, T1, and so on, the treatment was BCG. And so it is loaded with chemo, old-fashioned chemotherapy. So what do you see? Is it something that you would spontaneously use in intermediate risk, low-risk patients? It's very interesting in the way we do and we conceive the instillation within the bladder, but it's not perfect at the moment because only loaded with chemo. What is your opinion?
Well, if we look at the results of the TAR 200, which delivers just standard chemotherapy, gemcitabine, in the BCG unresponsive, and for this reason it was approved by FDA, I think the results are impressive, with a 90% complete response and in CIS containing patients. And I personally, I was myself impressive because I always thought that BCG, CIS treatment was BCG or immunotherapy centered because of this unique ability to lead to the disappearance of the tumor. But apparently, this is not the case. Certainly, I would not consider this type of bladder sparing treatment for the intermediate risk non-muscle invasive bladder cancer, which is predominantly a low-grade disease, which is known to be a non-aggressive disease with a very, very low risk of progression. Patients are not going to die of
I
this.
believe the way we revisit the instillation by using this kind of device to disseminate the drug is going to change a little bit the interaction of the drug with the tumor and to change the outcome of the treatment.
Well, of course, but going back to what you were mentioning about for instance, the more favorable disease, this kind of continuous delivery, which is probably what made effective what was actually not effective when delivered in the standard, in the old-fashioned way, like 1 hour or 2 hour weekly installations. Certainly, this is something that you could also consider in, for instance, cases where you have this multi-recurrent low-grade disease.
Very clear. Thank you so much. All good things have to come to an end, and I think it's time to close this webinar because we need to respect the deadline. I would like to thank again Professor Laura Mertens for being there tonight and interacting with us as a faculty. Thank you, Laura. Thank you again, Professor Paolo Gantero, for your input. We'll keep moving with the discussion within the masterclass of an NMIBC in Vienna for those who are participating, or online with the activity of the AU. Stay tuned, and thank you for being there tonight. Thank you. Bye-bye.